Good morning, ladies and gentlemen. Thank you very much for letting me present work undertaken at the Royal Cornwall Hospital exploring the presumed advantages of hip resurfacing at time of revision surgery. We have no conflicts of interest to declare. Hip resurfacing is purported to have a number of advantages for the patient. While there is evidence concerning the claims of better stability and function, there is no evidence in the literature to either support or refute the claim that the bone conservation element of hip resurfacing results in easier revision surgery with resultant better functional outcome. We therefore set to address this lack of knowledge by comparing the functional outcome markers of surgical difficulty in a matched cohort of primary revision resurfacing and standard hip replacement patients. Our primary outcome measure of interest was the Oxford Hip Score. Power analysis indicated we needed a minimum of 52 patients in each arm. Secondary outcome measures examined surrogates of surgical difficulty. These were length of surgery, blood transfusion, length of stay, implant complexity, and the need for further surgical procedure. Having sorted the relevant ethical approval, we undertook a retrospective review of all primary revision hip procedures for either a hip resurfacing or standard total hip replacement. We matched it on the basis of age and sex. Statistical tests took into account data distribution. Following data cleaning, we were left with 129 operations in each arm with a mean follow-up of 96 months. With respect to the primary outcome measure of Oxford Hip Score, there was a significant 6-point functional difference in favor of the resurfacing group. Length of surgery showed a significant 48-minute difference in favor of the resurfacing group. A similar advantage is shown in terms of a 17% difference in transfusion rate, and also in a significant 2-day difference in the length of stay. We assessed all radiographs and operation notes for the presence of implants additional to those one would find in a standard hip replacement. For example, long stems, augments, cages, and etc. If present, we market this as a procedure of increased implant complexity. Again, we see such implant complex operations are 10 times more likely in the standard hip revision group. The need for further revision surgery was again more likely in the standard hip replacement group. Although the mean time to the need for that revision was similar at approximately 3.5 years in both groups. We acknowledge the significant limitations of this study. Matching criteria were necessarily limited. For example, it would have been nice to have matched in terms of reason for revision, but as can be seen here, this would not have been possible without significantly limiting the cohort sizes. In conclusion, and going back to our opening slide, this study would indicate that bone conservation element of hip resurfacing may make for less traumatic revision procedure with better functional outcome. With concerns around metallosis, we recognize that resurfacing has fallen out of favor. As such, this study, while novel, may have a limited audience. However, this information remains of relevance when counseling young active patients about their arthroplasty options and may become pertinent in the future if the promise of ceramic resurfacing is ever realized. I hope you have enjoyed the talk and thank you very much for listening.